All right, good evening, everyone. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. And today I'm talking about type 1 diabetes. Is it a gut problem? Why am I talking about this? Because dealing with a lot of functional neurology issues, as they're termed, like dealing with those who have neuropathy, so to speak, we work with patients in their gut health who have type 2 diabetes and also type 1 diabetes. And I'm going to go through the literature tonight with some pretty exciting articles about the advances in our knowledge about gut health and type 1 diabetes. So without further ado, let me pan over to the presentation. And here we go. Okay. So this was first speculated back in the 1980s, I remember, or I believe reading, that they thought there was some association between the gastrointestinal tract and type 1 diabetes. It's a plausible association. Why? Because there's autoimmunity to the pancreas and type 1 diabetes. Very different than type 2 diabetes, which really does not involve autoimmunity to the pancreas. There is something being referred to as type 1.5 diabetes, which you can see in older adults where there is autoimmunity to the pancreas, but it has a different manifestation than type 1, as type 1 typically comes on before the age of 30 or 32, most often seen in children or adolescents. and basically it's this autoimmune response to the pancreas that then eventually leads to a critical situation where typically the child or the adolescent goes to the emergency room and they're lethargic and they may be urinating excessively and vomiting, and they hopefully don't, but sometimes have diabetic ketoacidosis. So it can be a very serious situation. Lots of times it's a huge shock to the parents and the child, and then they're left with this lifelong issue of having to administer insulin. So this first article I'm presenting, basically they're talking about the state of art regarding the gastrointestinal microbiota and type 1 diabetes. I just brought a few highlights from this Journal of Clinical Medicine to this presentation. So just so you know that I'm not pulling this out of thin air. And this article was published in 2019. The incidence of autoimmune type 1 diabetes is increasing worldwide, and disease onset tends to occur at a younger age. So that's a big finding. I'll show you a slide in a few minutes where they basically said that the incidence of type 1 diabetes is increasing by 3% per year, which is actually quite a bit. So there's something globally going on that's allowing this autoimmune disease, autoimmune means your immune system is attacking you, to become much more prevalent. And that seems to be the situation with most autoimmune diseases, which is causing researchers to scratch their head wondering why this is occurring. And they think it may be because of changes in the food supply. Maybe it's due to the amount of immunizations we get. It may be due to the wide spectrum use of antibiotics. Is it the fact that we have less parasites now and we live a much cleaner life, which overall sustains our lifespan, but maybe it's worse for our immune system? Those are the current theories. There's no definitive answer at this point in time, but that's what's being kicked around. Just the element of there being an association between the gastrointestinal tract and autoimmune diseases is a relatively new thought. And it's gaining a ton of ground in the literature. But in order for something to be a definitive association, it actually takes a lot of research and a lot of agreement amongst the scientists. So they go on to say, unfortunately, clinical trials aiming to detect predictive factors of disease in individuals with a high risk of type 1 diabetes mellitus reported negative results. So in essence, they aren't able to say what is predicting the disease for those who are at high risk. However, I'll show you some research articles which may swing against that. Again, this is published in 2019. I'll show you other research from 2019 as well, which was pretty interesting. So I really like this figure because it represents the issue pretty well. Here they talk about HLA susceptibility. So HLA susceptibility refers to your genetic probability or your genetic situation for a risk of developing an autoimmune disease. It basically refers to the human leukocyte antigen, and there are certain HLA patterns associated with certain autoimmune diseases. For example, with ankylosing spondylitis, where literally the spine fuses, they have an HLA B27 presentation. Whereas for diabetes type 1, I believe it's HLA-DR3/4. And there are many others. With celiac, it's HLA-DQ1 or HLA-DQB1. So they have all these different labels for them. But there's this genetic susceptibility for type 1 diabetes. And we also know that those who have type 1 diabetes can be more likely to develop Hashimoto's thyroiditis, and then may be more likely to develop celiac disease. And then there's something called autoimmune polyglandular syndrome, where then there's different types of that too, where maybe your adrenal glands are affected. So once you have one autoimmune disease, you're more likely to get others, but also the genetic susceptibility is very important. So we have that piece. Genetics is a piece, it's not the whole thing. Then we have the gut, as they represent in this figure, encompassed by this nice cylinder, which is basically what the gut is. The microbiome, 37 trillion gut bacteria we have. Those bacteria produce things like short-chain fatty acids. The short-chain fatty acids have an effect on local immunity. So if you have bacteria that aren't producing beneficial short-chain fatty acids like butyrate or beta-hydroxybutyrate, then that can have a negative impact on the local gut bacteria. And then all of that can play together in terms of gut inflammation and permeability. And then we combine those factors with environment. So how were you delivered? They're finding that gut bacteria are different between newborns born via C-section versus those born via vaginal birth. Breast formula and feeding, geographical location, diet, hygiene, lifestyle, antibiotics, everything I was talking about. So that is all coming together in our present day to influence why something like autoimmune disease, particularly here type 1 diabetes, is becoming more prevalent. Something in this situation is changing. It's very unlikely that our genetics have changed. So why are these autoimmune diseases exploding in their incidence and prevalence? So they talk here about basically type 1 diabetes being characterized by a pancreatic beta cell loss. And they go on to say that basically autoimmune beta cell destruction by autoimmune T cells progresses slowly, and hyperglycemia and symptomatic diabetes only develops when a critical mass of beta cells, about 80%, is lost. So once you lose 80% of the cells in your pancreas that produce insulin, the beta cells, that's when that urgent situation I described before, where an individual will feel weak and maybe they're peeing a lot and they're super hungry and they're super thirsty and they may be vomiting and they're going into diabetic ketoacidosis, they've lost 80% of their beta cell function by that point in time, which is, it's disheartening as a clinician when we see these situations. It's the same like with Parkinson's disease. With Parkinson's disease, which involves a lack of production of dopamine in a certain part of your midbrain, then typically by the time they develop symptoms, they've lost 80% of those dopaminergic neurons in the substantia nigra of their midbrain. So lots of times by the time the disease presents, a lot of physiology has been damaged. And so here they say the possible role of the microbiota being involved was first speculated in the 1980s, but then in the last 2 decades, we've seen a huge rise in the literature on the subject. And then they also commented regarding this link, fecal transplantation from basically NOD to non-obese diabetic resistant mice. So NOD are basically these diabetic mice. So if they take feces from a diabetic mouse, type 1 diabetes, to a non-obese diabetes resistant mouse, it caused insulinitis, or insulitis as they term it, indicating a diabetogenic effect of the non-obese diabetic mice and their microbiota. So basically, if you take the feces out of this mouse with type 1 diabetes and you put it into another mouse who's not supposed to get type 1 diabetes, they develop insulitis. They've shown that children diagnosed with type 1 diabetes have reduced microbial diversity. They've also shown that there are certain species from the Firmicutes phylum which produce protective short-chain fatty acids, including butyrate, that are less in type 1 diabetes, and there's an increase in the Bacteroides gram-negative populations, Bacteroides, so to speak, gram-negative bacteria. So you have this increase in gram-negative bacteria and this decrease in Firmicutes gram-positive bacteria, as you heard me talk about in the type 2 diabetes talk, that there tends to be this overgrowth of gram-negative bacteria that have lipopolysaccharides, which are inflammatory. This is a little different, but again, we see this dominance of gram-negative bacteria. So we have that. Now, this is a really cool article. I don't always show you articles from mice, just because I try to focus on the human studies because that's more applicable. There's a gazillion research endeavors going on with mice, because they're trying to see how does it translate to the human, and it doesn't always translate one-to-one. But I like this study just because we are seeing a lot of findings in humans on this matter, and I think this is a really nice representation of what may be going on. What they found in this study, looking again at non-obese diabetic mice versus the resistant mice to type 1 diabetes who are non-obese, basically, they saw this differential expression of zonulin. Zonulin is the protein in your intestines and colon that binds each epithelial cell together. Again, the epithelium of your intestines and colon is one cell layer thick. You have some mucosa involved around this one cell layer thick of epithelium. You have muscular layers. You have a nerve plexi running through the muscular layer. It's an environment unto itself, but the skin is very thin, and it's each skin cell is bound together by zonulin, occludin, basically, and there's transcellulin, I believe. There are a few different names, but zonulin and occludin are the major proteins that are commonly looked at. So here they immunofluoresced zonulin and occludin from these mice who had, they were type 1 diabetes basically, and they compared them to controls. Well, you can see here, if you just look at this, which A, B, C, D, or E looks to be the brightest. Certainly you're going to see fluorescence everywhere, but to me, that looks pretty bright. Through here, it looks pretty bright. And this is basically what they showed, and that this was early in the stage of the diabetes process. And then this is later in the stage of the diabetes process. So they see a lot of zonulin and occludin being basically manufactured and present, which is we could infer as being broken down in the intestines early in the stage of type 1 diabetes and later in the stage of type 1 diabetes, as compared to mice that didn't progress to diabetes and the other controls. I probably shouldn't have highlighted everything, but you can go back and read this if you want to. But in essence, they saw that the zonulin levels tend to be highest in the end-stage disease. They saw it increasing in the early-stage disease. And they saw that basically it was higher in the duodenum and jejunum. So as I mentioned 2 nights ago, your small intestines, think of it in 3 phases. Here's your stomach. The first phase is your duodenum, the next is your jejunum, and the next is your ileum. So they saw most of this zonulin being produced in the first part of the small intestine, the first 2/3, the duodenum and the jejunum. So that's interesting. So they saw a spatial difference, and they also saw a difference almost like time-wise, as we'd say, in a temporal association, where it was early in the stage of the disease, it was being produced, but as the disease process went on, a lot of zonulin and occludin being produced. Now, this is a really great article. I think this is from the Journal of Pediatrics, if I remember correctly. I can get you the link for anyone who wants it. And they here took a sample of children, And they basically, yes, 43 subjects, and it's a randomized controlled clinical trial where they basically took one group and they gave them prebiotics, and the other group they didn't give them anything, they gave them a placebo. And what they saw at 3 months was that their C peptide was significantly higher in the group who received prebiotics and was accompanied by a modest improvement in intestinal permeability. Now that's a huge deal. What is C peptide? C peptide is the precursor, or it binds on to insulin, basically. So C peptide is attached to insulin, and then once there's a process enzymatically where insulin is cleaved, and we have C peptide. Now, C peptide can then be a representation of how much insulin is being produced. And so C peptide was significantly higher in this group of type 1 diabetic children who received prebiotics. So nothing else. They didn't change their diet. They gave them prebiotics, I believe, in the form of inulin. Let me see. It was inulin for 12 weeks. And then after the 12 weeks, they looked at them again at 6 months, and they saw that the effects wore off once they went off of inulin. So that was really, really interesting. So this gives us some hope that maybe some element of pancreatic function may be able to return a little bit. Now, can we say that that person can go off insulin? No, that's not what I'm saying, and I'm not recommending that. But this was actually rather surprising for me to read, and seeing that based on their research that just with prebiotics, some pancreatic function recovered, which indicates, because the intestinal permeability improved, it indicates that, well, what else can we do to improve intestinal permeability, and can that pancreas heal to a certain degree, even greater than what they showed here? Let's see here. Okay, where was this out of? This was out of Stanford. This was a really nice review article where they basically just continue to demonstrate this association that there is a gut bacterial problem, and they showed that breakage of the gut barrier in mice carrying basically a T cell receptor specific for beta cell autoantigen leads to that autoimmune process. So a lot of people will say, the naysayers will say, yeah, there's research that the microbiota are just imbalanced in type 1 diabetes, but we don't know the exact mechanism. Here they're showing that breakage of the gut barrier integrity resulted in the type 1 diabetic autoimmune response. So that was big. That's out of Stanford. This article, I believe, is out of the journal PANAS. Oh, no, this is not out of PANAS. This was out of, I'm not sure if it was out of PANAS or not. It might have been. And here they basically looked at the gut microbiome, plasma short-chain fatty acids. They looked at small intestinal permeability in 47 children with islet cell autoimmunity. And they found that, in essence, the children with islet cell autoimmunity who progress to diabetes, like those with recent onset diabetes, have gut microbiome dysbiosis. So this is really cool too, because they're showing, we can see, if you're looking for it, we can see this autoimmunity start to develop before the type 1 diabetic process fully comes on. Again, as I mentioned, you have to lose 80% of your beta cells or beta cell function to develop type 1 diabetes, approximately. So here we can see autoimmunity in that pre-type 1 diabetic phase, which then raises the question, okay, if there's a family history of type 1 diabetes, if there's a family history of autoimmunity and you have a child, should you be checking that child semi-regularly for these autoantibodies? And a lot of doctors are going to say, no, there's no evidence, but also from the perspective of you as a parent, if that's something of interest to you, you can maybe look at contacting a doctor who will run the testing, because there are commercially available tests to check for islet cell antibodies and beta cell antibodies, and basically GAD antibodies, or a host of different antibodies you can run in the workup of type 1 diabetes. So, well, I said islet cell antibodies, which was redundant with beta cells, but you know what I mean. You can run these type 1 diabetic antibody profiles. So, and they also saw that the gut microbiome, the dysbiosis, was there. So the long and the short of it is that we have a bunch of smoking guns, and these smoking guns are now getting closer to pointing towards the exact molecular relationships whereby type 1 diabetes is stemming from a dysbiosis in the gut bacteria, whereby that breakdown in the intestinal barrier is seen possibly most in the duodenum and the jejunum, whereby somehow that bacterial dysbiosis and leaky gut, so to speak, then for those who are genetically susceptible results in autoantibody responses to the pancreas. And if that goes on long enough, then we lose 80% of the pancreatic beta cells and we lose that insulin. So that's the summary. That's what we know basically as of today, 2020, and maybe some of you have some other insights. I'd love to hear them. But again, I'm probably going to continue on a course right now of just focus on the gastrointestinal tract as it pertains to so many autoimmune and neurological diseases. And so you can be better informed, make better dietary decisions, make better testing decisions for you and your loved ones. Okay, so let me go back to Facebook. Okay, cool. And thank you everyone who joined, and have a lovely weekend, a lovely Friday night, and I will see you next week.